Reed and I are very excited to be here with you this afternoon to talk about redlining data and health research. I don't know that I really need to introduce myself beyond that nice introduction, but I'm Helen. I'm at the University of Michigan at the Institute for Social Research, and my background is that I'm a social and molecular epidemiologist.
Yep, and I'm Reed DeAngelis. I'm a postdoc at the Duke Aging Center, and my background training is in sociology. And so this is how our talk is going to go down. So first, we're going to give a brief background on the history of institutionalized segregation in the United States, and then we'll talk about the Homeowners Loan Corporation's redlining program in particular, and then give some examples of how to measure redlining with using the historical Hulk maps. And then along the way, we're going to be discussing potential mechanisms, linking historical redlining to like contemporary outcomes, as well as other mechanisms and moderators we should probably consider for future research. And then, of course, we're going to end the session with extended Q&A. Okay.
All right, so many of you are probably here because you're interested in place-based factors in health, and particularly one of those that we're interested is in racial residential segregation. And racial residential segregation is intensifying in the United States. So over 80% of US metro areas with greater than 200,000 residents are more segregated today than they were in 1990. And in particular, Rust Belt cities are disproportionately making up that top 10 most segregated cities in the US list. There's been lots of research on this, and that kind of documents that segregated communities of color in particular have higher neighborhood poverty, lower household incomes and home values, as well as lower home ownership. And so I've got an example of that stark racial residential segregation here on the left-hand side. This is Milwaukee, Wisconsin, and you can see the clear demarcations between the African-American population, those reporting Caucasian, Hispanic, and Asian in that city. And so you might be asking yourself, how did our cities get this way? Well, the stark racial residential segregation in the US in cities is by design. And we kind of have four hypothesized historical pillars that are driving residential segregation. And those include things like restrictive covenants. So that's the deed restrictions requiring the sale of properties to whites only. There are steering practices, which is when realtors would only show properties in segregated areas to the corresponding families. There's also social pressure and violence. So that's community pressure and mob harassment and violence against Black families purchasing properties, especially in whiter areas. And then we have redlining. And I'll turn it over to Reed to tell you what redlining is.
Yeah, so this section is going to be really about the historical programs of redlining. And so in broad terms, we could define redlining as sort of the systematic discriminatory practice of denying certain minority groups access to equal financial and housing opportunities. But just for a little historical context, redlining was first codified into law during the Great Depression and the New Deal eras, especially. So at that time, of course, housing markets were essentially on the brink of collapse, and the Fed decided it needed to step in and do something drastic to prevent such a collapse. So around 1934, we see the emergence of the Homeowners Loan Corporation, as well as the Federal Housing Administration. And so both organizations were initially tasked with basically just rescuing real estate markets. And the strategy they came up with was to issue federally insured, low interest and long-term amortizing mortgages to promote homeownership. And these, of course, are the mortgages that many of us take for granted today. I think the next slide gets into so of course, one major problem that lending institutions face is how to manage the risks of loaning to different types of borrowers. And so what organizations like Hulk and the FHA did was basically create these so-called residential security maps. And they essentially use these maps to identify different areas within major cities that were perceived as more or less risky for lending. So as you can see in this map here, Hulk and other organizations basically applied different color grades across the areas. So they assigned the green or A scores to the areas that were perceived as sort of best and on the rise. And these These were the up-and-coming affluent white suburbs of the time. And then the blue or B scores meant the area was still desirable, but already established and not rising. So these were kind of like old money neighborhoods at the time. And then yellow or C grades meant the area was in decline and that lenders should proceed with caution. And then the red or D scores meant the area was seen as hazardous and one that should be avoided entirely. And this, of course, is where the term redlining comes from. Of course, we now know that the lenders based their appraisals on really explicit racist beliefs concerning different racialized groups' capacities for like stewarding land and property. So if you're familiar, with, for instance, with like Cheryl Harris's work on whiteness as property, similar logic there. So this was, of course, in addition to other concerns about the age and aesthetics of houses, as well as the area proximity to different types of amenities and environmental hazards. But as this highlighted excerpt here from the FHA underwriting manual makes pretty clear, the racial composition of the area was a major like determining factor in the grades, right? So we can see that the appraisers were instructed, just to quote it, to investigate areas surrounding the location to determine whether or not incompatible racial and social groups are present, to the end that an intelligent prediction may be made regarding the possibility or probability of the location being invaded by such groups. And so these types of concerns about so-called invasions of undesirables were especially salient in the yellow areas, or the areas that were perceived as sort of on the decline, right? Because these areas were often nearby redlined areas where minority groups already predominated. So saying all this just to illustrate like the level of vigilance among appraisers of keeping so-called undesirable racial elements cut off from access to credit and housing. So we can go to the next slide. And so now we can kind of start to think about how historical redlining policies may be linked to like contemporary health inequities. And we like this 2022 conceptual model from Swope and colleagues. So at a bird's eye view, we can think of historical redlining as a sort of like an upstream political economic driver of downstream or individual level health outcomes. So for the sociologists in attendance, one way to think of this is in terms of fundamental causality, where redlining policies have ultimately structured population distributions of health risks and resources. So in this particular model, redlining is conceived of as like an observable manifestation of broader structural racism. And so redlining in turn is thought to structure individual and neighborhood level health risks and resources. So if we look at like the individual level pathway there, redlining is thought to create unequal opportunities for home ownership and wealth accumulation, which can then lead to poverty and stress and ultimately poor health. And then at the neighborhood level, redlining has also created entire areas of concentrated disadvantage and pollution, which in turn could affect the health of the residents in those areas. Okay.
So just to kind of clarify some of the conceptual model, we thought we'd give an example pathway. So we know that redlining influenced racialized perceptions of neighborhood value and practices that have perpetuated racial inequities in lending. And this has led to disinvestment in redlined neighborhoods. Disinvested neighborhoods have lower home values, less tax revenue to fund schools and services, and this could result potentially in poor education and reduced access to resources for residents. And we know all of these factors impact neighborhood health. In addition, the racialized perception of neighborhood value has resulted in restricted access to capital and equity to build wealth. So owning a home, which is one of the best ways to build wealth in the United States. And we also know that building wealth impacts health.
Okay, so with that sort of prelude, we're kind of finally get into like how we could actually measure redlining for our work. All right, so one obvious issue you first have to address is the discontinuities between historical redlining zones on the one hand and then like contemporary spatial measurements, so like census measures. And of course, there are a bunch of different ways you could approach this problem, but your choice of method should really be guided by, your specific research questions and analytic strategies that you want to use, and of course, the other types of data you're working with. We'll go to the next slide. And so we're showing you this table just to give you a general sense of how many different measurement choices are out there right now. Of course, we're not going to cover each and every one of these. If you want to check them all out, you can refer to that citation there at the bottom of the slide. But in our talk, we're going to be focusing on those two highlighted methods. So the first is the so-called GeoID method, which is considered to be the gold standard. This basically means you overlay individual like study participants' home addresses with the Hulk redlining maps. And we'll show you what this method looks like in a minute. But I just wanted to point out for now that one obvious limitation of this method is that few researchers are going to have access to the residential addresses of their study participants. So this is why we're also advocating for the second highlighted method, the so-called weighted score approach. And so Helen's going to show you what this method looks like in a couple minutes, but the general idea is to quantify the various spatial proportions of Hulk grades contained within designated land areas like census tracts or block groups, right? And then you can merge these area weighted scores into population studies that include like FIPS IDs for tracts or block groups. But again, more on this in a minute. So we can go to the next slide. And also very quickly, we want to like plug and acknowledge the Mapping Inequality Project out at the University of Richmond. So this is the group of historians who uncovered and then archived and then digitized all the original Hulk maps and field notes and basically put them online for anyone to interact with and download for free. So if you're interested in using these data for your own research or just kind of curious and want to look at the different redlined areas and their field notes, you should definitely go on to the Mapping Inequality website and kind of snoop around. Okay. And so here's, so we're going to start with the geocode method. And this is sort of a cartoonish depiction of what this method actually looks like. But so this image is depicting a Nashville block group map overlaid with its digitized historical redlining map. And so I'm going to ask you to imagine that the dots sort of scattered across the map represent study participants' physical addresses for their place of residence. So I think it's pretty obvious, sort of the next step, right? So for those who live inside the Hulk map boundaries, you can essentially assign each respondent to that respective Hulk grade based on their geocoded address. And then for the respondents who live outside Hulk map boundaries, you can assign proximity scores to the nearest Hulk graded area. And that's what we've done at the Carolina Population Center in the Ad Health study, which I'll show you more of in a minute. And of course, feel free to ask any clarifying questions about this during Q&A. I probably can't answer like technical GIS related questions, but I can refer you to our geographers at the Carolina Pop Center who did this work. Okay.
Great. So as Reed said, many health studies may not have specific geolocations for participants, but they will have their census tract assignment. And in addition, there's lots of other economic and social data that's available that we might want to link to redlining information, and that's also available at census tract or census block groups. And so to address the spatial mismatch between Hulk grade areas and present day census tract boundaries, we overlaid the Hulk maps from Mapping Inequality with census tract boundaries for 142 cities across the United States using ArcGIS. And we determined the proportion of Hulk residential security grades contained within the boundaries. Tracts with less than 20% graded were excluded, and we assigned a numerical value to each Hulk risk category. So 1 was for grade A, 2 for grade B, 3 for grade C, and 4 for grade D. We then calculated a continuous historic redlining score from the summed proportion of the Hulk residential security grades multiplied by that weighting factor based on the area that was within each census tract. So a higher score means greater redlining of that census tract, and a score closer to 1 means low redlining. And then we've also divided historic redlining scores into 4 intervals based on the national distribution of redlining scores, and included that as a categorical variable with a 5th category representing ungraded areas. So some analyses you might just be interested in the specific cities and the areas that were graded, and other analyses you might also want to understand that ungraded area. So that's in there as well. So for those of you like me who are super visual, this is just a different representation of that. As an example, so if a census tract had 50% graded A and 50% graded B, the calculation would be 1 times 0.5 plus 2 times 0.5, and that gives you a historic redlining score of 1.5. And so here's just another application of that. So you can see the Detroit original Hulk polygons on the left with the census tracts. This is a 2010 census tracts overlaid on top of those Hulk polygons. And then you can see the resulting historic redlining score on the right-hand side, and how those kind of deep red areas correspond with the graded D areas on the left. And so we've made this data publicly available. This is all this data for redlining scores for 2000, 2010, and 2020 census tract boundaries are publicly available for you to link to projects on Open ICPSR. If you go to Open ICPSR and type in historic redlining, it'll bring you to our data sets. And we felt it was really important to make this publicly available, not just for researchers, but also if there's any local community organizations who want to use this data. We're very passionate about an effort to democratize data and make it available to everybody. So again, we'd like to reiterate that there's multiple methods for overcoming that spatial mismatch between those original whole polygons and present day organization of data, particularly health research data. And we encourage you to explore the different methods and settle on the one that makes the most sense based on your research question, your analytic methods, and the data that you have available. Okay, so now we're going to shift into showing you some examples and applications of redlining and health research. As you can see on the left-hand side, I just pulled a quick PubMed search of citations from redlining and health. You know, the research in this area has really spiked in recent years, and that's thanks not only to our friends at Mapping Inequality, Rob Nelson and his group, but because they digitize these maps, but also increasing interest in examining structural drivers of health. And redlining has been linked to neighborhood level data and individual level data for various different outcomes. And I've just pulled some example titles of papers here. Okay, so first we'll go over some examples of ecological studies or neighborhood level findings. So I started this work when I was faculty at a different institution in Milwaukee, and we were really concerned with a lot of local health inequities there. So we looked at redlining in Milwaukee, and this is a table of Milwaukee census tract characteristics in 2010 by historic redlining score. And what we found was those racialized as Black in Milwaukee are disproportionately living in historically redlined areas. We also see concentrated disadvantage in neighborhoods that were redlined. These neighborhoods have 20 percentage point deficit in number of residents with a college education, an average median income of $20,000 less than non-redlined neighborhoods, and 15% less home ownership. And in particular, in some of the work that I do in thinking about place-based factors in health, homeownership is really important, not only for building wealth, but also to have autonomy to mitigate environmental hazards that might be in and around your home. So we wanted to know and first look at whether historic redlining was associated with current lending discrimination. And we measured current lending discrimination by either low lending occurrence, so the lack of access to capital, or predatory lending. And we found that tracts with a redlining score of 4 had 40% increased probability of current lending discrimination versus tracts with a redlining score of 1. Second, our results found that historic redlining was associated with current neighborhood mental and physical health. So as displayed here, we see higher historic redlining was associated with higher prevalence of both poor physical and mental health in Milwaukee. And then lastly, we wanted to understand sustained disinvestment. So this is tracts that were both redlined, but also had current lending discrimination. And we found that sustained disinvestment was associated with higher prevalence of poor mental health issues, as well as poor physical health, even though I'm not showing that specific result here. So those initial results from Milwaukee, that's just one city. So then we conducted a national study of redlining and current neighborhood health and sociodemographic indicators. And we saw, as you might expect, that whole redlining was associated with present day high minority, high poverty neighborhoods with shorter average life expectancy and higher neighborhood prevalence of chronic diseases and worse physical and mental health. And so I've kind of got the table here showing you the difference between the best areas and redlined areas nationally. But I'll call your attention over to the left-hand side with just a call out from Richmond, Virginia, showcasing the differences between two specific neighborhoods. We've got our green neighborhood with an average age or average life expectancy of about 85 years very low poverty, and it's a majority white neighborhood now, and versus a redlined area, which is now has a life expectancy of less than 70 years, very high poverty, and it's also a majority minority neighborhood. And so, just some of these very, very stark differences even within one city. So some other work we've done, kind of looking at the neighborhood level, is trying to understand neighborhood and these place-based risk factors, in particular healthcare access. And so we wanted to understand the patterning of healthcare access by redlining. So nationally, we saw lower prevalence of physicians, mental health specific physicians, and mental health practitioners in redlined areas. So we've got our intervals on the bottom, and again, remember that 5 bucket is that ungraded area. So you'll see them kind of bounce around in these results. Conversely, we also saw prevalence of no health insurance being much higher in redlined areas versus those areas that were not redlined. And then we saw similar trends in dental access and health as well. So there are less dentists per 1,000 in redlined areas versus non-redlined areas. And thinking about those health behaviors, less people have visited a dentist in the prior year in redlined areas versus non-redlined areas. And we see a pretty stark difference in the prevalence of no teeth in individuals over age 65 in redlined areas versus non-redlined areas. So as you go on to work in the space, I just, again, want to draw your attention to the importance of place. So giving you some national results here, but each city or urban area has their own history, their own story. So it's important. Sorry, was there a question?
What is that really a big like girl costume?
It's the Grinch.
The Grinch.
Yeah.
So please mute yourself if you're not the speaker.
Okay. There's always one, right? No. Okay, so each urban area has their own history and their own story. So it's important to connect to community and understand that local context. Each city is going to have different immigrant patterns, different migration patterns, different physical geography, different social fabric. And I think that's all important to consider. So I just have an example here. So when you consult the Hulk area descriptions for the decision by assessors to redline neighborhoods in Milwaukee, the logic there was overwhelmingly anti-immigrant and anti-Semitic racism, versus, if you'll remember back to the Richmond map a few slides ago, that was clearly anti-Black racism. Milwaukee's Black population largely arrived in the second Great Migration, which occurred after the Hulk maps were made. So, you've got to consider that historical context when you're doing this work. Regardless, the legacy of these redlining decisions have racialized space and impacted trajectories of neighborhood, and we claim it's by design. And that's gone on to influence the health of residents, who weren't even born when these determinations were made. So that's kind of just a summary of some of the work that I've done at the neighborhood level. And so now I'll turn it back over to Reed to kick us off talking about specific applications in cohort studies.
Yep. Yeah, so I'm going to share some preliminary findings from AdHealth. So for those unfamiliar with the data, AdHealth is a nationally representative cohort of adolescents who were recruited from grade schools across the country in 1994 and 1995, and they've since been followed for 25 years, or roughly 25 years into adulthood. And so what we did was basically merge each respondent's geocoded addresses with the full set of Hulk redlining maps across 4 waves of data spanning from adolescence to adulthood. And so these data are now publicly available, so you can check those out. And this would be the document you'd want to refer to when you look at those data. This document's available on the Carolina Population Center website. You can go to the next slide. Okay, so I'm just going to share with you some of our initial findings among the AdHealth cohort. So this figure here is looking at who lives within redlining map boundaries. And so for this analysis, we're including Black, Hispanic, and white respondents. And they're going to be represented by the green, red, and blue rectangles, respectively. And then along the horizontal axis, we're looking at the respondents' redlining status in adolescence and adulthood, so W1 and W5, referring to waves 1 and wave 5. And so the label NH stands for no Hulk, and this is going to refer to anyone who lives outside of the Hulk redlining boundaries. And then we looked at the blue, green, and or BG, and yellow and red or YR groups together. And then the vertical axis is going to show the proportion of the respondents who fall into each of these redlining categories. We can go to the next. So the first big takeaway is that most respondents do not live inside redlining map boundaries in adolescence or adulthood. And so these numbers here suggest around 60 to 80% live outside these areas. This makes sense when you consider that these maps were drawn almost a century ago, right before decades of suburban sprawl. So we really shouldn't expect a ton of people to live inside formerly redlined urban centers today, compared to the newer suburbs, at least. And we can go to the next slide. And so, but that's not to imply that the redlined areas are empty, obviously. So the group over on the far right of the horizontal axis is the group we're really concerned about the most. So these are respondents who live in yellow or redlined areas at wave 1 and wave 5 or across the life course. And we can see here that this group is disproportionately Black and Hispanic. So around 10% of Black and Hispanic respondents fall into this group compared to around 2 to 3% of white respondents. And if you scoot over about 2 groups to the left, you can see that an even larger proportion of Black and Hispanic respondents lived in yellow and redlined areas in adolescence, but now live outside of the redlining map boundaries as adults. So the proportions here are closer to 15%. And we can go to the next slide. And so now we can quickly look. I have a few examples of some adulthood health outcomes associated with the different redlining group statuses. So this is looking at self-rated health at wave 5. And so in this example, self-rated health is scaled from 0 to 100. Higher scores mean better health. And that dashed red line represents the sample average. And so we're looking for any significant deviations from that dashed red line. We can go next. And so what we're finding so far is that respondents who live in yellow or redlined areas in adulthood or across adolescence to adulthood tend to report significantly worse health relative to the rest of the sample. And this is after accounting for age, sex, race, and measures of adolescent and adulthood socioeconomic status. We can go to the next slide. And so now we're looking at the probability of respondents reporting any functional or mobility limitations at wave 5, right? So in this case, respondents who live in the yellow or redlined areas in adolescence, or again, across adolescence to adulthood, also tend to report higher probabilities of having a mobility limitation as an adult. And this appears to be on a magnitude of about 5 to 10% higher probability. Go to the next slide. And then this will be the last outcome I show you from that health. So we're looking now at wave 5 allostatic load. This is basically just a count of high risk biomarkers related to the cardiometabolic and immune system. So in other words, higher scores are bad. And so again, we find that respondents who live in yellow or redlined areas across the life course have the highest allostatic load scores on average. And now also their peers who lived outside the redlining map boundaries in adolescence also appear to have the lowest allostatic load scores on average. So obviously we're going to talk about this maybe a little bit later, but we need to unpack this ungraded category a little bit more. We don't know if these are rural, suburban, or urban groups, but that's an area that we're moving into in the future. So, okay.
Great. So I'll complement the ad health data with some data from health and retirement study. So the health and retirement study is a longitudinal panel study that surveys a representative probability sample of approximately 20,000 Americans over the age of 50 every 2 years. It was launched in 1992, and like ad health, the study has lots of information about income, work, assets, health insurance, physical health and functioning, cognitive functioning, biomarkers, and psychosocial data. And the original sample, as depicted by the cohort sample design, is supplemented with a new birth cohort every 6 years. So we've linked historic redlining data to HRS participant census tracts. To access participant census tracts, you'll need to complete a restricted data agreement. The HRS has this process outlined on their website, so I'll just refer you there. But once your restricted data agreement is approved, you'll be granted access to geo-identifiers through the Michigan Center on the Demography of Aging, or MICTA Enclave. They have a virtual desktop system. And so just to give you an example of some of the work that we're doing in HRS, we've observed associations with redlining and life expectancy at a neighborhood level. And so we're interested in seeing if that replicates looking at individual mortality risk. And so this is just some descriptive table of historic redlining and demographic characteristics in the HRS. And you can see that we observe expected associations between redlining and the distribution of race ethnicity in our population, with those living in higher redlining being more likely to be Black or Hispanic participants. There's lower educational achievement and higher neighborhood poverty, as well as higher measures of the CDC's social vulnerability index. And then when we looked at the associations between redlining and mortality, we saw that redlining was associated with greater odds of mortality, and that this association was attenuated when we adjusted for likely mediators like education and neighborhood poverty. And when we looked at the intersectional effect of race ethnicity and redlining, we saw an association for those racialized as Black living in formerly redlined areas and 4-year mortality as well. So these are just some examples of the type of work that's out there in these larger cohort studies. So I'll turn it back over to Reed to talk about future directions.
Yep. And so I think one major task going forward in this area of research is going to be to unpack all of these mechanisms, linking historical redlining policies to contemporary health inequities. And so, as you can imagine, there's a pretty big black box problem in this line of work. So in other words, I think we're starting to gather all these very compelling findings showing disparities across the whole graded areas today, but we now need to kind of nail down exactly how and why these patterns are surfacing. And so, looking at some of the examples here, I think one major mechanism to consider would be environmental pollution, because there are a growing number of studies that find that formerly redlined areas still have higher levels of pollution, especially compared to higher green-lined and other suburban areas. I think other contenders include things like psychosocial stressors. So for instance, chronic exposure to violence or neighborhood social disorder. We may also want to consider disparities in access to healthcare, as Helen showed earlier, and then also food and nutrition and maybe other aspects of the built and natural environment. So I'm thinking, for example, of say proximity to green space versus highways or automobile infrastructure. And then if, as Helen pointed out, we should also be looking, I think, into contemporary measures of redlining, disinvestment, and displacement or gentrification within historically redlined areas. You can go to the next slide. And so I just wanted to share with you an example of a model that I'm currently testing in a Nashville-based community sample of Black and white working age adults called the Nashville Stress and Health Study. And so I chose this model because it combines a lot of the different elements of what we've been talking about today. So for one, I used Helen's weighting method to assign Black and white residents to block groups that were predominantly redlined. So, and then I linked these 4 groups to these area level proxy measures for air and water pollution. Those were provided by the EPA. And then in turn, I was able to link some of the residents' health outcomes to these different pollution measures. So in this case, I'm looking at reports of past year lung conditions, as well as the respondents' telomere lengths as a gauge of cellular aging. But obviously, this is just one of many potential examples of the type of multi-level models that we may want to start testing going forward, especially if we want to try to nail down some of these environmental mechanisms linking the individual respondent's health to living within a formerly redlined area. Go.
So just wanted to mention some other future areas of redlining research. And so use Carolyn Swope's very helpful conceptual diagram to kind of guide us through it. So I think one area is going to be considering other housing policies and practices like urban renewal. So if you're not familiar, the federal government provided funding to cities, both large and small cities, to raise blighted or slummed neighborhoods. And the goal of this program was to, create improved housing opportunities and stimulate commercial and industrial redevelopment. But through these programs, cities displaced hundreds of thousands of families from their homes and neighborhoods. And so if this is something that interests you, I encourage you to check out the folks at Mapping Inequality. Rob Nelson and his team have Renewing Inequality, and that will guide you through some really excellent visualizations and understanding kind of that displacement that occurred as a result of urban renewal. And then another key thing that we need to capture better is thinking about neighborhood change over time in everything from, both racialized displacement, but also segregation and concentrated disadvantage. And then, as Reed alluded to in some of his work, thinking about these individual level moderators, right? So things like coping behaviors, both individual and neighborhood social support might be really interesting areas of future research. And then, of course, both AdHealth and HRS, as well as other longitudinal cohort studies, are great for understanding multi-level longitudinal associations, and we should leverage them for that. And then the last area that I think, coming at a lot of this as a life course epidemiologist and thinking about the timing of exposure, and Reed got into some of this with his comparison of adolescent and adult living in redlined areas. And so thinking about kind of like the duration of living in historically redlined areas versus, so that like an accumulation model versus maybe a sensitive period model. I think that there's a lot of research that can be done in that area as well. And so then just to kind of bring us home, the intentional, explicit, and implicit racialization of physical space to enact and reinforce racial boundaries and racial hierarchy over centuries has shaped, the neighborhoods that we live in and the places and cities in the United States. And this figure shows the chronology of major race ethnic segregation strategies, laws, Supreme Court decisions over time. And, we want to highlight that redlining is just one piece of a really big, complicated puzzle here. However, it is a piece for which we have a really quality remaining historical record. So we have this Hulk redlining maps with the accompanying very explicitly racist area descriptions. And so there's really, no confusion in what was going on. But there are other federal housing programs out there like FHA who had maps as well. And those maps were destroyed as a result of they were sued. So, we understand that, redlining is not the end all be all. There were other things going on. And we just want to make sure that that's communicated to you all as well as you move into this space and work, is that, this is really a proxy for all of these, processes and institutions that were going on at that time. So that brings us to the end of our kind of formal presentation here. We just want to acknowledge our funding and, obviously give a shout out and thank you to the Network on Life Course Health Dynamics and Disparities for allowing us to have this time with you this afternoon. And so I think Reed and I are happy to take your questions and we'll do our best and go from there.
Yeah.
Thank you both so much. This is amazing. I learned a lot, not only about data sets, but also theory and models and how to think about issues of redlining and racism and modern day health dynamics and disparities. So thank you both so much. This is really fabulous. So we have time and they've generously agreed to stay with us for a while. So please, I don't know if you want to leave your slides up or just this would be a little bit better so people could ask questions in your little cubes, and if you wanted to show up personally, that would be great, and or put questions in the chat. While you're starting that, can I maybe take the prerogative of asking the first one, and hopefully folks will jump in here. So my question is, I'm really curious as well about this number 5, these non-Hulk graded areas. So Reed and I have talked about this a bit here, but for researchers just starting to get into this area, there's from the AdHealth based data, 60 to 80% of individuals in AdHealth don't live in these graded areas. Obviously, you got rural people in rural areas, suburban areas, and so forth. But can you, either of you or both of you, give us some advice on strategies you might think about in terms of comparison between people who do live in these areas? Or do we, I would hate to drop 60 to 80% of our data, but this seems like a really heterogeneous group of people. So anyway, any advice you can give us on the 3/4 or so people who don't live in these formerly redlined mapped areas would be really, really helpful, at least for me, and hopefully for a lot of folks.
You want me to go first?
Oh, sure. Yeah.
Or go ahead. Yeah.
I was just going to comment on one thing, because so I know that, like, so in the ad health data, we have those proximity scores as well. So one thing I'm interested in is knowing if, like, say, you don't live in the boundary, but you're so I think we break it down like within a mile, within 1 to 5 miles, and then so on and so forth, like further out. I would be curious to know if living like just within, like, or just outside of the boundary is similar to living inside. I would imagine it would be. And then also, I mean, in the ad health study, what we could do is take that ungraded group and then break them into different categories based, because we have measures on like the percent, like rural, like in the census tract or something, or like the racial and socioeconomic compositions. We can start combining, I think, those different indicators and create different ungraded categories. I think that would be how I would go about doing it. What about you, Helen?
Yeah, so I've actually spent a lot of time thinking about these ungraded categories, because it's a large portion of when you start to get into looking at individual level data, it's a large portion of the study sample. So if you look at the maps, it's going to be a combination of industrial. These are urban ungraded areas, are going to be a combination of industrial, commercial, and then agricultural. And so I will say, Rob Nelson of Mapping Inequality is a co-investigator with me on a grant, and on a grant I have, and they are about to publish, I don't want to like throw them under the bus and have it wrong, but it should be available in early 2024. They're going to give they've updated their mapping inequality data so that there's also polygons for industrial and commercial data that they've pulled from the map. So at least we can kind of look and maybe, combine the industrial and commercial and understand those, which may have gentrified and now a lot of people live in, things like that. And then another project that we have is, and this is the grant that we have, is leveraging other historical resources out there. So there's the Sanborn fire insurance maps. For those of you who aren't urban historians, these are maps that are parcel level, and they were made for fire insurance. It's amazing what money prompted, right, to measure back in the day. And so we are overlaying the Sanborn maps with the ungraded areas in Hulk maps to kind of understand what was actually going on in there in terms of historic environmental hazards as well. So that's an ongoing project we have. In terms of how to use it analytically now, I usually restrict to urban ungraded to at least kind of like pull out that, so you can have rural ungraded, urban ungraded, and HRS has kind of their, I think it's the Beal statistic, on urbanicity. So I divide it into urban ungraded, rural ungraded, and I usually drop the rural ungraded because I'm thinking about cities. And so that's one way to do it. And I've been using it as my reference category because theoretically, these are areas that were not exposed to this policy. And so it gives you that comparison. But it's, this is just our first foray into trying to understand how best to categorize them. And so I think a lot of work hopefully will be done in that space because our cities have changed since Hulk, and it's important to capture that information as well.
Thank you both so much. That's super thoughtful and helpful. Megan.
Hi, thank you. This was super helpful. I'm just starting my dissertation and hoping to work with some of this data. So I really appreciate this talk. I had a question specifically, I believe for you, Helen. You mentioned earlier measuring predatory lending in some kind of way. And I was wondering if like what data or methodological approaches you took to do that.
Yeah, so we used home mortgage, HMDA, HMDA, Home Mortgage Disclosure Act data. And this is data that we have since the 1980s. The 1980s data is pretty sketchy. The 1990 through present day is much better. And this is another aspect of a grant that we're working on in trying to understand neighborhood trajectories of lending over time. And so I'd say, especially if you're doing a dissertation, any data in there from 2018 to present is really, really probably good. We're working on compiling a longitudinal HMDA data resource that again will make publicly available, but that's probably not going to happen until sometime in 2024. But we're in our kind of like beta testing of it all right now. But that data is so if you just go in and download HMDA data, it's loan level data. So then we have aggregated that to census tracts to link. So you can get estimations of, in our paper we used, so there's an indicator of predatory lending is rate spread, and I refer you to our paper to kind of look at how we categorize that. But because we also had very low lending occurrence in some census tracts, we use kind of current discrimination as either low lending occurrence or this high predatory high predatory lending indicator of rate spread. But you can also look at things like number of originations, just, be really mindful of, how you're going to normalize it or your denominator. So make sure that you're controlling for, if you're going to use number of originations, you want to control for also the number of like housing units in that census tract, and things like that. So, hopefully there'll be more from our group in the future and have this public resource out there. But the HMDA data is another great resource. And if I could plug, this is work, but this is work from a team, and I have collaborators. I am an epidemiologist, and so when we first got into this for that Milwaukee paper, we were connected with the National Community Reinvestment Coalition, which is a economic justice nonprofit who are experts in the HMDA data and in lending, and we could do none of this without them. So I encourage interdisciplinary science in tackling some of these really complicated things that might be outside of your normal wheelhouse.
Great, thank you so much. And moving on from Megan, Alexander, do you have a question? And other questions, please, folks, raise your hands or put questions in the chat. Thanks.
Thank you so much. I have hopefully a really quick question for Helen, and a little more in depth for Reed, if that's okay. Helen, you said it's linked to HRS. Is that like readily requestable with the restricted use agreement?
So we're hoping to make that a user contributed data product here shortly. Right now, you would just import the, until we can get that finalized, you would just import, like we've imported the redlining scores from in, and you just merge it with the census tracts.
Got it.
But we do hope that that will be, I assume you're familiar with HRS. Do you know how like the NANDA data is in there and linkable? We're hoping that that will be coming soon.
Wonderful. Thank you. And Reed, I had a question. I'm just starting to use the redlining data in Ad Health, and I don't know if you've thought about this. There's so many things that can be done. It's quite complex. But there's a lot of contextual variables that are measured at the census tract, race, demographics of tracts, poverty, etc. And so something that I was trying to build out was like also contextual measures of like racial segregation and poverty and how that might intersect with redlining. But the redlining is linked to residential addresses, and those census tract things are broader. You kind of referenced like challenges with linking. It seemed a little messy. I wasn't sure if you've I don't know, thought through that, or based on your knowledge, if there's any issues with doing that.
Yeah, so I've just started kind of looking at the neighborhood level measures. Yeah, my sense is like we might want to do, they may have to do certain like latent variable analysis, latent class analysis to try to identify different types of like, so I'm imagining you get the respondents who live in certain either in or out of certain like redlined areas, link them to a different, like a variety of different indicators at the census tract level to get at, because I'm also curious about like maybe redlined areas have gentrified or like different, like, yeah. So I guess in like short answer, no, I haven't started like digging too deeply into the neighborhood level measures, but my sense is it's going to have to either be through some sort of a priori like theoretical reasoning, or try like a latent class approach to try to identify different categories of broader neighborhoods. But yeah, I imagine it's going to get, especially because it's averaging out over the whole US, and we don't have, I mean, we do have regional, like the 4 big US Census region indicators. But yeah, I wish I had a better answer. Maybe if you want to follow up with me over email and like give me more of like your particular like things that you're running into, I'd be curious to see what you're coming up with.
I appreciate that, and I will definitely be in touch.
Yeah, please.
To follow up about many questions. So.
Yeah, please. That would be great.
Thanks, Alexander and Samantha. Before we get to your question, there's a question in the chat from Javier Rodriguez. Javier, it's great to hear from you again. And to see you here at the workshop. And Javier asks, have you been able to detect any factor in your models that attenuate the health effect of redlining? So I know, Reed, you touched on a bit, and Helen, maybe if you have any experience with that as well, that would be great to hear from you on that.
Helen, did you want to?
Sure.
I have those church findings.
Yeah.
Would that be something that would be worth showing?
Yeah, let me bring those up. And while I'm doing that, if you know, and I think this is advocating again for thinking about, you know, theory and the research questions you're asking, because, you know, we go through this all the time in these papers, is that a lot of the current neighborhood factors that you might, even some individual level factors that you would want to adjust for in your models, are actually mediators, right? And so when you adjust for them, you would naturally, as I showed in the mortality analysis, like when we adjusted for neighborhood poverty, we saw some attenuation, and that's to be expected, because that would be downstream and on the pathway between, you know, these historic structural racism and, you know, current health. And then let me bring up Reed's.
Yeah, so like in terms of like maybe attenuate like in a buffering fashion, I've been starting to look at like community like church concentrations and religious involvement, because I think there's another aspect of redlined neighbors that we should also pay attention to. It's not all about, I think there's also sources of resiliency in a lot of the redlined neighbors. So this is again looking at the Nashville Stress and Health Study and looking at Black and white residents in redlined versus non-redlined areas. This is, I think that's actually from the NANDA data set. Census tract, this would be tract level, like number of churches per square mile. And that 0 there, that's for the non-redlined white residents. That's like zeroed out. That doesn't mean there are 0 churches. It just means that's their mean. And so for the Black residents of redlined areas, they have about 5 or 6 more churches per square mile than the white non-redlined. And then we can go to the next one. This is just looking at the Black residents. This question was only asked for Black residents, but the probability of the Black redlined residents attending an all-Black church is about 25% versus about 18% for their more suburban non-redlined Black peers. So there's more churches, and then the Black residents in the redlined areas are more likely to attend like an all-Black church. And then we can go on to the next one here. The redlined Black residents also report the highest levels of public religious involvement. Sorry, next one. I'm going to fire hose y'all here. No, sorry. Highest levels of optimism. Right. So these are, and fewest, and yeah, that's good. Highest levels of optimism, and fewest depressive symptoms. And I find similar patterns with like loneliness and a couple of other subjective well-being measures. So yes, so the redlined Black neighborhoods that I was looking at, they had more pollution, and some of their physical health outcomes were worse, but in terms of like community and subjective well-being, they were actually kind of better off in certain senses. So I think we should, this is something I'm getting interested in looking at too. So I don't know if that's what you meant by attenuate, but that's thinking like in terms of like stress buffering, coping resources, that could be one thing to look at.
Fascinating. Javier, thank you for the question, and Helen and Reed for the responses. Really great. Samantha.
Yeah, thank you so much. It was a great workshop. I really appreciate it. I have a question because I've been working in this space more with the historical data. And I don't know if you're aware of this paper in +1 by Noelke and colleagues. It's looking at more of a classification approach to calculating the Redline score. And so basically, my question is, I, like you, am using the approach from the NCRC in terms of calculating the redlining score. But do you know about, it's the accuracy or the validity in the score? If that's been compared, the paper in +1 uses a more categorically based kind of strategy. And it uses like the area, and it's a complicated method to show, how you calculate the HOLC score. I think where it may do better than the method that the NCRC is advocating is when you have, for example, like a census tract, and you have an ungraded portion of the census tract, and then you have like the graded 1 through 4. I think their method may offer a better strategy. However, their paper doesn't explicitly compare the NCRC method with their method. So I'm just wondering, are you aware of any other attempts by researchers to compare the validity of the NCRC method versus other methods out there?
Yeah, so the paper that we showed that had the list of the different types of methods is a recent paper out of Lauren McCullough's group down at Emory that looked at, GOID as the gold standard, and then several other methods, including, so the NCRC method, that's my method, and then we partnered with them. So they do a really thorough job of looking at sensitivity and specificity of the different methods. I don't think that they pulled the, I believe that's the Minnesota group's paper that you're talking about. I don't believe that they pulled theirs to include it. Probably a timing issue because there's a more recent paper. I think that for ease of interpretation, and so I would refer you to this paper. I just put it in the chat to kind of check out their analysis. They did a really good, they pulled data from real estate in Atlanta, and there's some limitations there. It's only looking at Atlanta versus across the nation. I think that there's strengths and limitations to all methods, and I think that we acknowledge those limitations. The weighted score approach that we use was shown to be very sensitive, and if I don't want to go all epi on people, but when we think about exposure misclassification and the randomifications of that, to me, I am okay if a tract if we might be overestimating a redline exposure, because unless something was entirely graded A, they were exposed, that neighborhood was exposed to some sort of lending discrimination, right? And so, I think if we think about the nature of the bias and as well, I think that's an important exercise, right? And so if our method slightly over estimates maybe an exposure to redlining, I feel like that's a bias I can handle. I think I haven't looked really closely at the Minnesota one. But I would refer you to the paper that I put in the chat because they do a great job of kind of going through all the different methods. I don't know if Reed, if you have anything else you want to add.
Thank you. Thanks a lot. That's very
Yeah, sure.
helpful.
And thank you, Helen. And there's a follow-up there. So it's asking Samantha, you didn't know you had to do work to come to this. But can you share the citation for the
I just put it in the chat.
Okay, thank you. Thank you.
And
Helen.
I think did
Yeah.
they make their data publicly available too? I'm not sure. I feel like they might have.
Just attach it in the, I'll try to attach it in the chat right now.
Okay. Thank you so much. And now there's another question in the chat from Javier Rodriguez. Thank you. And he's asking if there's any unexpected observations in which redlining doesn't show the detrimental effects that we expect. For example, a set of identifiable census tracts where the detrimental effects are null, a bit related to Reed's earlier idea. So maybe you could talk a little bit about kind of counter examples if you have them available.
Yeah, I mean, some that I'm finding in the ad health cohort, but it's kind of, so like, for instance, for Black and Hispanic respondents who grow up in green or blue areas in adolescence, their adult outcomes aren't great compared to the white respondents who do. I don't know, I wouldn't necessarily call that unexpected, but I think it's important to consider that living within formerly redlined areas might mean something different for like the individual race ethnicity of the residents. And then also there's some indication, like for instance, the white respondents in ad health who lived outside of the urban centers but then moved into redlined areas in adulthood are like among the most privileged groups in ad health. So they have like the highest college completion rates and better health and stuff. So that kind of seems to imply some sort of gentrification process going on where they're moving into redlined areas that were gentrified. Again, I don't know if I would call that unexpected, but I think there are sources of heterogeneity that we need to unpack. And I think that a lot of that has to boil down to doing like sort of multi-level analyses to see who's moving in and out of these areas and what their individual life chances look like. Helen, I don't know if you got something.
I mean, I'm trying to think. I think this is, again, like if I can advocate for having good theoretical backed research questions, I think that's gonna, when we do the, like, have you guys seen that cartoon where it's like you spin the wheel, this exposure is associated with spin the wheel, this outcome in spin the wheel, this population, right? When we start to just plug and chug things instead of have theory guided research questions, I'm sure that we'll find more unexpected, things that you might not expect or null findings. But I think in the space that's out, or the people that are working in this out there now, for the most part, I think things are pretty, you're kind of aligning up the way that they would be expected to. I think I always wonder when we do national studies, what local influences are being masked. And so I think, depending on certain, like if you're looking in certain cities, and again, depending on those local, even things like geographic barriers, right? Like Milwaukee has 3 rivers. I've always really wanted to compare it to Pittsburgh because Pittsburgh also has 3 rivers. Just thinking about all of these, differences, like, do you find different things in different cities because of maybe, some of the processes that have enacted in different ways in different areas? But I can't think of anything like glaring on the top of my brain that was truly unexpected.
Very thoughtful. Thank you both for that. And Javier, thanks you as well in the chat. Samantha, thanks for posting that paper in the chat. That's much appreciated. Okay, other questions or comments? Okay, if not, Helen and Reed have posted their, put their emails, made their emails available. And again, we've recorded this, and along with those recordings, I think the slides will be available. That's and you're getting plenty of applause there as well. Personally, I thank you both very much. This is super cool. This is amazing work that you're doing and data that you're making available to very broad groups. So, which is kind of the community service of science that is so going to be so important for pushing field forward and better understanding racism and its implications for health and health disparities in American society. So with that, I think we'll conclude the workshop for today. Thanks to the National Institute on Aging for sponsoring this workshop, and we really appreciate it. Thank you, Helen and Reed, and we'll have a good weekend. Okay, appreciate it, everyone. Thanks all.